Okay, we're going to be going over a systematic review that talks about how to reduce soreness after dry needling. We'll look into some of the specific studies that they looked at within this systematic review. So initially they talk about how between 29 and 100% of patients are going to experience some sort of soreness for a few days after dry needling, but most papers say it's somewhere between 50 and 100%. Honestly, your patients should be getting a little bit sore when you are dry needling them. If not, you're probably not going to have the best results. Many of that, or much of that soreness is going to be influenced by the technique, how you're manipulating that needle, the intensity, the needle gauge, and even psychosocial factors. And this is a really key point here, is that 51% of patients would be reluctant to repeat dry needling given the level of post-dry needling soreness. So if you make your patient miserably sore after dry needling them, they may not want to do it again, up to 51% of them. And that being the case, you could be stopping a treatment early due to post-dry needling soreness that would prevent the opportunity for significant pain reduction. I've talked about this before, but if you are overdosing your patients and you make them incredibly sore, they're not going to want this treatment again. And if you do that, you might have just taken away an intervention that could have gotten rid of their symptoms. So this is a really, really big deal as to try to get, try to keep that soreness at the lowest level possible. The purpose of this systematic review was to identify and assess the quality of evidence of interventions that might reduce post-dry needling soreness. We're going to get right into this. So there are 8 trials that they looked at with over 500 patients. The first study is looking at low-load eccentric exercise after dry needling. In this, the patients had subacromial pain syndrome, and they had active trigger points in their infraspinatus. They put a needle in the infraspinatus, and then they followed it with low-load eccentric exercise. And then in the placebo group, they used ultrasound, but it was inactive. So the ultrasound machine was turned off. So that was their placebo. They followed them up immediately. And then at 24 hours and 48 hours later, the low-load eccentric exercise significantly reduced the post-dry needling soreness immediately at 24 hours and at 48 hours compared to the control and the placebo. So there you go. We've talked about this, in that exercise can really help reduce some of the soreness that they're going to experience after dry needling. You just want to probably keep that at a lower level. In this study, they looked specifically at eccentrics. The next study looked at concentrics versus isometrics versus eccentric exercise and how that related to post-dry needling soreness. This was in latent trigger points in their medial gastroc. Follow-up was immediate at 6 hours, 12 hours, 24 hours, 48 hours, and 72 hours. A really big deal in this study is that they inserted the needle up to 50 times. Now, if you have had a needle put in your gastroc, you know that just a few insertions is already going to make you sore. So imagine what their results are going to be if they put a needle in 50 times or 50 insertions. And I think in this one, they were specifically looking for twitches as well. And you would imagine that there's no significant differences found between the active groups and the non-exercise control group. That's because of likely how they needle them, and that they're not going to have good results just because they made them pretty miserable by inserting the needle 50 times. All right, next group. We're looking at kinesiotaping after needling. So really we're going to be quick with this one. They follow them immediately, 24 hours, 48 hours, and 72 hours later. KT tape did not work. Really isn't good reason to be putting tape on your patients after dry needling them. Next one is percutaneous electrical nerve stimulation. Now this one did work. They had 62 patients with chronic neck pain. The groups they all had a needle in their upper trap. They either had low frequency or high frequency percutaneous electrical nerve stimulation, or they were just a control group and they had nothing afterward. They followed them 24 hours, 48 hours, and 72 hours later, and they were able to have significant improvements in pain at the time points with dry needling plus percutaneous electrical nerve stimulation. Now, unfortunately, I cannot find this article open access anywhere, so I was not able to read the actual article and see the methods behind it, but it's something. Percutaneous electrical nerve stimulation is putting electrodes onto needles, and then some of it was superficial, some of it was deep based off of the abstract from this article. But again, not open access, so I wasn't really able to look deeper into it, but there are a bunch of different ways that we can also reduce soreness. Point is, this did work. Next is a spray and stretch. So they put a needle in the upper trap in these subjects. They follow them up with a spray and stretch, and that significantly decreased the immediate post-dry needling soreness. That was not present at 6 hours, 24 hours, or 48 hours later. By 72 hours, the dry needling soreness had disappeared in both groups. So spray and stretch spray and stretch may reduce post-dry needling soreness immediately after needling, but it doesn't work at 6 hours later. Next is ischemic compression. With this, they essentially just applied pressure onto the area after they removed the needle. So in this, they applied this pressure for 2 minutes in a latent to myofascial trigger point. This was in the upper trap as well. What they did this in 90 asymptomatic participants, and after applying that compression in that latent trigger point, they found that they were able to immediately reduce that soreness, and also at 48 hours later. So up to 2 minutes of ischemic compression had the ability to decrease both severity and duration of post-dry needling soreness. Next is the patient's perception or their expectations with that dry needling soreness. So this is talking to them about either positive expectations or negative expectations with dry needling. This is not the actual amount of soreness, but more of their attitude towards that soreness. And it didn't change anything. So talking to your patient about what to expect does not change their attitude based off of that soreness. Same thing with the verbal suggestion and expectation setting. So letting your patients know that they are to experience soreness afterward does not reduce their actual soreness afterward. So while I still think it's important to talk to patients about their expectations, just recognize that it's not going to change their perception of that soreness, nor is it going to change their actual soreness post-dry needling. All right, and then the authors concluded that verbal expectation did not influence the patient's experience in post-dry needling soreness. We're going to get right into the discussion. So with the discussion, they talk about how 3 of the 7 trials reported that they did dry needling until there were no more localized twitch responses seen. And then another one required at least 2 localized twitch responses, and then 2 of them did not specify. Just recognize that more twitch responses is going to mean more soreness in your patient. So if you're going out looking for those twitches, which we know there is a poor correlation in the short term and no correlation in long term with outcomes and twitch responses. Again, I do like to see a twitch response if I'm treating a muscle, just to know that I'm doing something. But if you just get a bunch of twitches, you're going to make them more sore. So that's at least in the specification of twitch responses. And then they talk about this study that we already went over where they had 50 insertions of the needle during dry needling procedure. This is uncommonly high and may have worsened their pain. You guys can expect that. That's going to make you sore as hell. Conclusion is that low load exercise, percutaneous electrical nerve stimulation, spray and stretch, and ischemic compression all appear to perform better than placebo in single trials at reducing post-dry needling soreness and could warrant further study and clinical use. Their key points is that those are the same procedures are the ones that work. So low load exercise, percutaneous electrical nerve stimulation, spray and stretch, and ischemic compression. Anecdotally, a few things that can work to reduce some of the soreness post-dry needling. One is go over some of their home exercises afterward. Get them moving in some capacity, and that'll typically reduce some of their soreness. It'll slowly start to dissipate as soon as they start moving around. So like let's say you treated, low back pain. You put needles in their low back. You're going to want them to get up and start walking around a little bit. And then maybe you want them to start moving their spine. So maybe work on some flexion extension depending on their sensitivities. Maybe you want them to pick up some weights, some neutral ab exercises, so like pal-off presses or maybe some pullovers, things along those lines, just to try to get them moving a little bit and get the muscles to activate. You could also have them stretch. You could have, you could put a hot pack on them. I actually do some of that ischemic compression. I'll just apply some pressure right on that area. But a hot pack honestly can work pretty well just because they're kind of just chilling there. That's going to reduce some of the soreness, as we know heat packs do. But in general, if you just have them kind of wait a little bit before they just head out the door, that'll already make them a little bit less sore. Exercise is probably the most common way that I'm reducing soreness after dry needling. And then I typically, especially the first time that I needle somebody, I'm following it up with an email. So although those studies say that it didn't change their attitude towards the soreness, nor did it actually reduce their soreness, I still think it's a really big deal to talk to your patients about what to expect, because if you make them, every patient is a little bit different. So if you overdose them, obviously on accident, and they get incredibly sore, well, they might think that you just messed them up in some way. And just setting up sending them an email afterwards saying, hey, you can expect to be a bit sore. It should last a day or two. If it lasts longer than that, maybe you could put a heat pack on it, take a warm bath, get some movement in, let them know what to do about it so they can feel empowered. But also you want to make sure that they know that you did not do something incorrectly, that you have good experience in this, you've done it before. All of that can still make a change in a lot of ways. But yeah, the point of it is that you want to try to get them moving in some form in order to reduce some of their soreness afterward. Ischemic compression can work well. I'm not using any spray and stretch. I'm not using technically percutaneous electrical nerve stimulation. And if you guys have any questions as to how to reduce soreness in your patients, or if a patient is incredibly sore and you guys have anything you want to discuss, please post it in the group. Let's go over it. And that way we can really help each other get better at treating our patients, and we can really help each other level up. All right, we'll talk soon.